The wheezing increases when he goes to the gym. He has started going to the gym. And he was diagnosed with mild asthma. He was prescribed by the general practitioner, he was prescribed salbutamol, 2 puffs when needed, and beclomethasone, 50 micrograms daily. Our question was the pharmacology of beta beta 2 agonist and inhaled corticosteroid. The beclomethasone is an inhaled corticosteroid, while the salbutamol is a beta 2 agonist. So I will be telling us the mechanism of action of beclomethasone, which is an inhaled corticosteroid. Prior to this, we heard that for any asthma diagnosis, you must give them an inhaled corticosteroid. It is essential to prevent future exacerbation, to control the asthma, and yes, it's a controller. So mechanism of action of beclomethasone. Sone, we know when we hear sone, we know it's a corticosteroid. So beclomethasone is a glucocorticoid. It works by binding to the glucocorticoid receptor. It's working locally. So it's binding to the glucocorticoid receptor in the airway cells and the lung epithelial cells. So it will form a drug receptor complex. So from the cell, it will now move into the nucleus where it will cause two things to happen. One, it will inhibit the gene, it will inhibit it will inhibit expression of genes, and it will also cause expression of genes. By inhibiting expression of genes, it's inhibiting that for pro-inflammatory factors. Pro-inflammatory factors are the ones that will cause inflammation. So it inhibits the gene expression for those ones, while it will cause expression of anti-inflammatory proteins, thus reducing the inflammation of the airways.
And to take the pharmacokinetics of inhaled corticosteroids. So if I tell you the kinetics, it's not going to be interesting. So in Gen Z language, work with me as we are taking the admin of beclomethasone. So when you take the drug, if for whoever, okay, when they take the drug, when Mr. BD takes the drug, he will press it into his mouth and then it is absorbed. So, like we learned in pharmaceutics, the pressure hits it right into the throat, the end of the throat, and then now only a small percentage of that goes to the lungs to act, and which is about 10%. The rest enters systemic circulation and then it remains in the bloodstream. So that takes us to the distribution where it tells us that only 94 to 90 that about 94 to 96% is protein bound. So this explains to us that what happens to the remaining one that doesn't act at the lungs, right? So it stays bound to the proteins, right? And then it is now released over time. So that's what happens with it. Then that part that stays in the body, as we know, it's acting as a reservoir. Then for metabolism, it is metabolized in the liver. And then now beclomethasone has the as the original form, the parent compound is active. Now the metabolized part is also more active, and it is metabolized by hydrolysis, which means addition of the OH group, which makes it to be excreted easily. As for excretion, it is excreted in the feces with about less than 10% excreted in urine. For the adverse effects, like I said earlier, it is basically oropharyngeal candidiasis, and that can be stopped by two things: using a spacer and then rinsing the mouth after actuation.
Good afternoon, class. So I'll be talking on the pharmacology of salbutamol, which was administered to my patient, which is an 18-year-old patient. So the pharmacology of salbutamol, we all know that salbutamol is a drug
Are you
beta 2
listening?
under beta 2 agonist. So in terms of the mechanism of action, um, beta 2 agonists, they actually stimulate the beta 2 adrenergic receptors. And what do? They actually cause the phosphorylation of cyclic AMP and protein kinase. And then this phosphorylation of the cyclic AMP and protein kinase, what does it do? It causes bronchodilation as well as um, the relaxation of the bronchial smooth muscle. So now in terms of the types, I would say other beta two agonists they will have the short acting and the long acting. So I won't really bore you guys on the long acting because the area of interest is the salbutamol, which is the short acting drug. So in terms of salbutamol, we know that its absorption it actually absorbed rapidly in the body, and then in terms of metabolism, it metabolizes the liver, and in terms of the duration, it takes 4 to 6 hours, and in elimination, it's actually eliminated in the urine. And also, the patient asked the question if short-acting drugs can be co-administered with long-acting drugs. Yes, it can because it can be administered in severe cases. Now, what do long-acting and short-acting do? Like, you want to know the difference between long-acting and short-acting. Short-acting, they are actually hydrophilic. They bind to like the affinity that they have for the receptors is actually small. So it won't and it's actually used to treat mild cases of asthma. That's in terms of like quick relief. While long acting, they are lipophilic, which means that they have a strong affinity for the receptors, making it um, okay, it's actually used in maintaining like as a maintenance therapy for treatment.
All right. Somebody said something about protein binding. Who said it? So, how? What does protein binding? That knowledge. What does it confer on the management of that patient? As a pharmacist, how can you exploit the knowledge of the protein binding capacity of a drug? How can that translate to clinical information?
Okay, sir, if when you actuate the drug, if the patient when the patient actuates the drug and all of it goes to the site of action, none is stored in the bloodstream because
This
this
patient, this drug has what the protein binding was what?
94 to 96%.
So,
Yes, I'm going there.
okay.
Okay, so if all of the drug goes to act at the site of action, the effect is not going to be sustained for a long period of time. So that's the essence of the protein binding. So that the protein binding basically acts as a reservoir for the drug. That's just what it acts as. So it releases this drug over time to go to the site of action and perform its action.
Is that you agree with her? What's the clinical implication for protein, highly protein bound drug and low protein bound drug? Why do we include such information in drug leaflets? It's vital. That's why they include it. So if you say it acts as a result, so why do we repeat those if there's a
What's the
reservoir?
legal relevance of that information you're giving us?
Uh,
So it for me, in my own understanding, it depends on the type of drugs.
is your
Because
understanding a universal understanding?
some part of
Or
it
why are you restricting the pharmacy to you? The knowledge is universal.
so for some drugs that they say are highly protein bound, this means that these drugs are highly distributed. So
What do you mean?
the at the barrier when at the site of action there's a barrier, or at tissue sites, yes, there's that barrier. And then from what we learned in year three, I think there's this layer, the bilipid layer, that is there, and then there are transmembrane proteins, there are other things there. So if a drug is highly protein bound to those transmembrane proteins, they can easily be distributed into the tissue and perform their actions.
Wait,
Any help from
a pro-
uh,
which drug actually acts on the site? Is it a bound form or the unbound form? Eh?
Your bank
Unbound form. You're not contradicting yourself. Which drug actually is fitted? The bound or the unbound?
your bank.
Unbound. So it will bind to those proteins and get released from the proteins at the site of action.
To help her, I think before a drug can actually work, it needs to be bound. process. So I think highly bound drugs, they are less distributed in the system, and then drugs that are lowly bound, like the unbound drugs, they are highly distributed in the system, leading to a therapeutic and physiological effect.